If everybody could take their seats. Huh? All right. Hi, how are you? Okay, can I get everyone to take their seats, please? Thank you all. I think what we've tried to do a little bit this morning is start with the federal perspective, give you a little sense of some best practices on the ground, and we are lucky enough at this time to have your state director of long-term care services to sort of give you an update of where things are here in Wisconsin. So we're going to give him some time to present, and then there will be some time for questions afterwards. So with that, I'd like to turn it over to Brian Shoup. I hope I pronounced that correctly.
Shoup is the last name.
Shoup, okay. Thank you. My apologies, and the microphone is yours.
Well, thank you. Good morning, everyone, and I want to thank the National Council for inviting us and for that matter for holding this meeting. Let me start by saying that our Family Care and IRIS program have enjoyed bipartisan support and the support of 4 governors since its inception back in 1998. And if I'm off on a year or two about these dates, you'll forgive me. But the planning actually started for family care in 1995, I believe. Started then with pilot counties in 1998, and it was subsequently expanded. Currently, we're just completing the expansion of 7 counties in northeast Wisconsin, and that will leave only 8 counties that are still in what we call the legacy waiver program and that have not expanded yet into family care and to IRIS. As I said, these 2 programs have enjoyed bipartisan support from the very beginning. Even though there have been, the legislature has not always seen eye to eye on various components of the program, there is no question about the fact that there has been continuing broad support, and I think you can expect that we will continue to see that regardless of the administration, regardless of who is elected to the legislature. Family care and IRIS, I believe, really vaulted Wisconsin into a leadership role throughout all 50 states in this country. We're proud of that. 2 years ago, when Secretary Kitty Rhodes appointed me and offered me the position, I asked her, what are the deliverables you expect? And her response was to make sure that Wisconsin remains a leader in the state. Actually, let me correct that. What she said was to ensure that Wisconsin is the leader in the state. She did not say a leader. She did not say one among other leaders. I want Wisconsin to be a leader in the state. Well, that was a pretty stirring deliverable that she handed to me, and I can tell you that our division and the leadership of the entire department takes that seriously. We take that seriously because our mission is to serve the folks that are in need of long-term care. Let me just go over, and I think most of you probably in the room know this, but there may be some that don't know this. Family care is a prepaid managed care, long-term care program serving 3 target groups: the frail elders, those with physical disabilities, and those with developmental and intellectual disabilities. And it's funded on federal Medicaid dollars, state what we call GPR, general purpose revenue, and also county levy funds. There are currently 9 managed care organizations that are prepaid on a per member per month acuity adjusted basis. They're capitated. And these 9 include 6 what we call in statute district managed care organizations. And basically, these were formed by several counties, groups of counties coming together and creating a managed care organization, an MCO, and I'll just use the term MCO. They have since expanded into other regions in the state. Also included in these 9 MCOs is one county MCO, Milwaukee County Family Care. There are also 2 nonprofit managed care organizations, and there is one proprietary for-profit organization that also currently is one of the Medicaid HMOs on what we call the card side of the programs. These MCOs in turn contract with providers, and these providers form their provider network. There is also family care partnership, and it differs from the standard family care program by already integrating acute, primary, behavioral health under a managed care environment, and to enable all this care to be coordinated. For the target group of frail elders, of course, for folks that are dually eligible for Medicaid and Medicare, they coordinate that care along with that. So what's the key? What was one of the most compelling reasons to establishing family care in Iris, and what happens as we will continue to expand family care throughout the state, is that it's an entitlement program. And by that, we mean any waiting lists under our legacy Medicaid program, long-term care program, will be eliminated. Let me talk a little bit about the IRIS program. The IRIS program is a fully self-directed long-term care program where eligible consumers or guardians using Medicaid, Wisconsin Medicaid dollars, hire their own team to provide supports which allows them to live in the community. It has been a very fast-growing, popular program. There are today 12,000 members. These IRIS consumers are assisted by consulting and fiscal agencies. They have a budget that they work with, and they direct their own care. As a side note, I want to mention this as well. There probably is no bigger proponent that has served in the legislature, has served in Wisconsin state government than my current boss, Secretary Kitty Rhodes. She has historically been a strong advocate of IRIS and continues to be a strong advocate of IRIS, and that will ensure that it will remain a critical program in our long-term care array of services. Well, let me talk a little bit about Act 55. Act 55 is the current biennium budget that was passed several months ago. And as I think most of you, this budget attracted a whole lot of interest, and no one knows that better than I do, judging from the phone calls, letters, et cetera, that we've received. Let me tell you first what the budget requires, and then I want to talk a little bit about what our plan is, what the planning process is to go forward with the design. We've been calling what will be the reformed family care and IRIS program, we've been referring to that as Family Care and IRIS 2.0. 1.0 is the current program, and we will be moving to 2.0. it does a number of things. First of all, instead of managed care organizations, that concept will be replaced by what the legislature has referred to as IHAs, or integrated health agencies. The one thing that we do know is that they will be licensed as insurance companies. One of the key provisions of Family Care 2.0 will be that we will be required to integrate primary, acute, behavioral health, and long-term care benefits all in one package. It will be integrated. And I'll come back to that in a second. The IHAs will also, well, let me start all over with that. IRIS, according to the new budget, will be integrated into family care. Now, what does that mean? That means that the IHAs will be required to provide the consulting and fiscal services that are currently available to IRIS members. Also, the budget is very specific about this, and that is that all of the long-term care services that currently under IRIS version 1.0 will be continued under IRIS 2.0. So if you are an IRIS member, you will be able to self-direct any service that is currently available right now under the current IRIS program. The budget also states that any MCO is able to become an IHA upon meeting the qualifications and requirements. And a word about that. The Office of Insurance Commissioner will determine what is going to be required for an IHA to the extent of reserve requirements and solvency requirements and those sorts of things. It will be the Department of Health Services, our department, that will draft the requirements, the contractual requirements that IHAs will have to meet. Within that arrangement, organizations including insurance companies, HMOs, the current MCOs are free to negotiate joint ventures or other cooperative arrangements to serve, or subcontracts to serve as IHAs in the future development of family care and also IRIS. Our department will be required to file a concept plan to the Joint Finance Committee by April 1st, 2016. And that is prior to any waiver application that we might make. We're also directed in the budget to expand family care to all counties by 1/1/17, or upon CMS approval, or upon, to some degree, some discretion of the department's ability to, and its capacity to develop the concept and implement it. By the way, I thought Lynn Breedlove really drafted an excellent summary on the changes in Chapter 55, and if you haven't read that, I would encourage you to read that. And I see Lynn on the front row in the end there, and I appreciate that. Oh, you did. In fact, with your permission, we may use that. So where are we at today? And I want to leave some time for questions. I will tell you that the way we're approaching these changes are that we are starting largely with a clean sheet of paper. And by that, here's what I mean. The budget itself provides a broad outline for what the legislature and the governor have intended to be the reforms, and we're using that as a broad outline. Within that skeletal shell, we will be charged with designing the program. And to design this program, we will be first soliciting stakeholder input. Now, in the budget, we're required to hold a minimum of 2 public hearings. We're going to hold 8. In addition to that, we will be pulling in various stakeholders, consumers, advocates. If we are curious about what some groups might have to say, we will be pulling them in and having dialogue with them. In fact, we've already started that process this morning. We had 2 consumers that we spent an hour with this morning regarding their concerns about IRIS, and we will continue to do that. But let me go back to the public hearings. The first one will be scheduled, I believe, Julie, on the 19th of September. September 9th, okay, thank you. We are having to move fast. As most of you have seen, the deadline for implementation is 1/1/17, and we want to make a good faith effort to try to meet that deadline if we can. Therefore, we're on a very fast track. However, I will go over what our plans are for the stakeholder input in terms of the public hearings. We will have 8. The locations will be Green Bay, Wausau, Hayward, La Crosse, Madison, and Milwaukee. In Madison, we will hold 2 public hearings. One will be a general public hearing. The other will be a public hearing specifically to allow some dialogue with various advocacy organizations, and we will be inviting a cross-section of long-term care advocates to that, and we look forward to that. We'll also be holding a meeting with the tribes as well, and that we have not yet firmed up a location for that. The first meeting, though, is on the 9th, and that will be in Green Bay. The other dates are still being arranged, as I understand it. The format for these public hearings will be, we will begin with a slide presentation. We understand that there will be a real variety of folks that will be attending these, giving us testimony or giving us written testimony. So we understand that we can't count that everybody will understand what's in the budget, so we'll be giving a brief presentation, a PowerPoint presentation on what the budget requires and how we're going forward with this. We will also be developing various questions that we will use to try to provoke some testimony, and we will get that out in advance as well. These will be key decisions that we have to make that we specifically would like to solicit input on. Folks are free to advise us on any issue that they wish, but to give it some additional structure, there are some specific issues that we particularly are going to be interested in. In terms of our planning, this is what we have done thus far, in addition to the communications plan that I just outlined. We took a broad section of our management team, I believe 3 weeks ago, and we held a retreat. And we invited our management team down to the section chief level, and that included anyone who touches upon any of our adult long-term care programs. We identified 140 approximately 140 key decisions that we're going to have to make. Now notice, this is important, we did not make 140 key decisions. We identified 140 key decisions that we're going to have to make. And from that list of 140, I expect that to grow somewhat as we continue to go through the planning process. Of that, we will draw from that the key decisions that we'd like some input from. And that list may grow as well. We have also, at that retreat, we developed a charter. We have retained a project manager for it, and we expect to probably add at least 2 more project managers to assist us with this. And we're going to be moving at a pretty rapid pace. One of the things that we did decide on is a philosophy about how we're going to plan this, and that is it's going to be that waiver follows design. Waiver follows design, and I'll tell you what we mean by that. We're going to come up with a design that we feel is the optimum delivery system based on testimony we receive, based on consumer input, based on our experience, and based on our data. And then we're going to look at the waiver authority. We're not going to do this in reverse. Part of the reason we're going to do this is because this goes back to my nonprofit days years ago, when we would develop a program or a program model, and instead of looking first at what foundation would be flush in our minds with some money that we might go tap, and then design a program according to what their guidelines are, I found out very early at a young age that that's a disastrous way to advance your mission, and it's a good way to not establish any rapport with the foundation. That's the analogy here. We feel it's important to have the design first, and then we'll look for the waiver that it best fits in, and if we have to make some modifications, we'll make modifications at that time in terms of our waiver proposal. Also, since we're talking about waiver proposals, we're talking about CMS, and I want to make it clear that on April of 16, we have to present a concept paper to Joint Finance Committee.
About a minute, please.
And the Joint Finance Committee will do an up or down vote based on the concept paper that we present. If it approves it, we will go forward, develop a waiver amendment, and submit that, and then there will be another public comment period that anyone of interest, stakeholders, consumers, providers, can comment on the actual waiver. There's probably a lot more that I could say. I'm mindful of the time, so I want to open it up to any questions that you might have.
Thank you very much. I believe that Councilor Ari has a question.
So I'll ask a brief question so as to make sure that the audience has time to follow up with their own. But my question is with respect to the broader vision you have for moving into this new model. You mentioned that the existing MCOs within the state that were organized on the regional and county basis were encouraged to seek joint ventures and collaborations with some of the new players. Do you anticipate requiring some of the potential new entrants into the Wisconsin market to collaborate with or form any kind of strategic partnership with some of the existing MCOs that may have more in-depth expertise at specific populations?
Well, that's a good question. Let me first make one minor correction to your question. I think our position with respect to any joint ventures, any collaborations among our current MCOs and any future candidates for IHAs, we're taking a neutral stance. We expect that market forces will drive any of those collaborations, and I would go this far, that our secretary has certainly been strong in encouraging market forces in many different areas of our current system, and that will continue. So just that minor correction. Do we expect that there will be collaborations? I have heard that there are discussions among some of the current MCOs and larger payers already. So I would, where they're going, I'm not privy to. But frankly, it would probably make sense for payers who don't have who have their experience on the acute primary behavioral health side, might well want to collaborate with MCOs that have some years of experience now delivering long-term care services. So that would not surprise me. As to whether there would be further specialization along the lines that you're saying, that would not surprise me either. But our department is taking a neutral stance. We are not going around soliciting what they're doing.
Thank you.
Welcome.
I guess I'd ask if any questions from our audience.
Yes, there is one on the right.
Okay, we have one over here to the right. Can you? Okay, go ahead.
I have a question and a comment. My question is, you said that the people that are presently involved in IRIS will be able to continue with the kind of programming that they're used to having. But you didn't say that new people going forward would have that same opportunity. And I was just wondering if that was going to be the case.
Well, the short answer is yes. I hope what I said, and I may not have said it precisely, is that any existing or future IRIS member will be able to continue to self-direct any service that is currently able to be self-directed in the IRIS program today.
Okay, so anybody who chooses to can still do that?
They will still have that choice, correct?
Okay. And my comment is...
But can I just add one thing? I know that during the budget process, one of the most common comments that I heard from consumers was something that went like, we understand that right now in the current family care program, there is already exists some limited ability to self-direct some of their care, but that's not the same as IRIS. We agree with that. It would not be the same. That's not what we have in mind. I'm sorry.
Okay, and my comment is, I've heard two different ways of stakeholders definition in my head. And I just want to make sure that when you all are putting together your committees with stakeholders, that they include actually consumers, not just the people providing the services as the stakeholders. That's just me.
Well, I'm going to respond to that comment. I hope you heard me say consumers multiple times, and if there's any, let me make sure there's no mistake here. When I talk about stakeholders, I'm including the full array of interested parties. It goes all the way through from consumers to their families, to advocates, to providers, to potential IHAs, to MCOs, and I left out anyone who has an interest. Fill it in for me, please.
A question here from the table?
Yes, left side.
Left side.
Thank you. Just following up on stakeholder involvement, I understand that the department will be deciding in the next couple of weeks how to roll out either Family Care 1.0 or 2.0 in the legacy counties. And I'm curious what your plan is for stakeholder involvement in that rollout decision.
That decision has generally been, that's a decision that's already been made. There may be an exception or two. We have at least one county that has already, some time back, passed the statutorily required county board resolution indicating that they wanted to roll in to family care. We also heard from other counties that felt very strongly that they do not want to go through a transition, a change twice. That is to say that they don't want to first roll into family care version 1.0 and then do it all over again sometime in 1917. We are, so the decision that we're making is that we generally agree with that, but we want to be sensitive to perhaps one county that has been asking to transition into family care. And we'll be giving them a choice, and they're going to take that under advisement and get back to us. You're welcome.
Okay, do we have any other questions from our audience? Another one? Okay. Go ahead.
I can hear you fine. And I'm sorry, after saying that I could hear you fine, I missed some of what you said, but let me take a, can I take a stab at it? First of all, we want to hear a lot of consumer input about this. We want to hear from all stakeholders about that. But I have to tell you that the decision to integrate it, to integrate IRIS into family care has already been made and signed into law. So having said that, we have a number of issues that will be key decisions. One is, an obvious one, is how do we ensure that this integration of family care into an IHA that will be responsible, how can we ensure that the operation will be conflict of interest free? And that's going to be a big one. And I would ask Julie here to write that down because I want to make sure that gets added to, I want to make sure we have that in our key decisions. That will be an important one. We want the experience, all of the positive experience for IRIS enrollees to not just remain the same, we want to continue to improve it. There are some things that we feel need to be improved with IRIS. One of them, and I was just talking about this earlier this morning in a meeting, is we have a small subset of our population of people with developmental disabilities that present very challenging behaviors at times. And from our experience, sometimes they end up under an emergency detention and end up in one of the state mental health institutes or in a private or a county psychiatric hospital. And the problem is that under the current IRIS program, they're disenrolled. My team is not set up to provide case management. We do not provide direct services. We are just not, we're neither budgeted for that, nor are our people trained. But yet, when that happens, we have had individuals that linger in psychiatric facilities because of the lack of somebody to case manage them. And that's critical. It's not doing justice to those who are in IRIS. One of the things that integrating IRIS can do is that integrating it into family care can accomplish is that there will be an IHA with case management team that at that point can jump in and provide some assistance. In addition, because individual IRIS members are disenrolled when they go into an institution for like a psychiatric hospital, they're disenrolled and they have to go through enrollment counseling all over again. There ought to be a way to streamline that. And those are a couple improvements that we see as really important to make. I didn't cover your concerns about rates, I believe. Let me take a stab at least what I think might be part of your concern is it's clear that you believe now folks are in IRIS are being well served through the consulting agencies and the fiscal agencies. Right. Just as we talked about a few minutes ago, I answered some questions about current MCOs and perhaps future IHAs collaborating, forming joint ventures, subcontracting. Those same things would be possible in IRIS as well. And my understanding is I've been told there is some of that discussion going on currently.
Okay, all right. It's about lunchtime, and I just wonder, are there one more questions? You've got the guy here that's designing the system here in your state. One more chance to ask him a question.
My designing it, I'll have to correct that.
All right. I'll stand corrected now that I'm at least coordinating the design. How's that? Okay.
That's good.
So
got two
Brian, this morning, the representative from CMS said that they're going to require that states put together stakeholder groups as they develop this process. So when can we expect to be told who will be in this group and the level of authority that it will have in terms of not just listen or providing input one way, but actually participating in the internal decisions at the department that are going to result in this radical change to our system?
Well, I think Mitch, and thank you for that question. I think that one of the things that we want to do is have a discussion to make sure that we're in compliance with CMS expectations and requirements there. So that would be the first thing that I would like to say. The second thing would be, I think we're really interested in the precise language that CMS expects. Ultimately, I will tell you that the department is the entity that is accountable to the governor and accountable to the legislature on this, and the ultimate decisions will be the federal government and CMS in terms of what they may approve or may not approve with a waiver, and to get that approval, we would have to be compliant with all their expectations. But we also have an accountability to the legislature and the governor, and we have to make sure that we make decisions in a credible way that is compliant with those two parts of our state government as well.
Okay, we have time for one more question, I think. Yeah, we have a young woman here at the table.
Yes, she is.
So we hear a lot of kind of back and forth here. On one hand, we have experts who are speaking, who are saying that the current program we have has been held up as a gold standard, and how not only in a fiscally, but also in the quality of life of the people receiving these supports, that we are the gold standard, and yet we're choosing to move away from that. If this is for a fiscal reason, I admit I'm a little bit confused. We currently have an average of $4.4 million in surplus in the program that goes back into state coffers. Where are those funds going to go in this new program? If we have out-of-state for-profit companies that are receiving these contracts, what is there for incentive of care if the excess funds are their profit?
We will control administrative costs. We will control, as we do now, the margins that an ICA makes. I don't anticipate any change in terms of the authority that we have and how we exercise it. Let me say something about the gold standard. We owe everything to the folks in the beginning that came up with family care. I remember about 3 months after I started, I sat through a 2-hour briefing that I wanted to hear from some of our longer-term folks that were around when family care was first designed. And I think we have a clear responsibility to maintain the goals, the intent, and the vision that came from that group, and we want to do it justice. I also will say that I think I'm proud of the fact that they, with the help of advocates, consumers, et cetera, came up with this program. We want to do it justice, but we also need to be careful about when we remain static and say we have a gold standard here, let's never change it. I worked in a mission-driven healthcare system, faith-driven healthcare system for several years. I had merged a nonprofit that I was running into that organization. And they, like most healthcare systems today, pursue a course of quality improvement. Theirs was continuous quality improvement. And it wasn't just a sign. It wasn't just a phrase they used. They were serious about it. The Good Sisters never felt that they had achieved perfection in any of their services. There was always room for improvement. And I think that we in the state of Wisconsin could take a page from that. I think it's important to do that. If you aren't constantly looking at areas that you can improve, you're standing still.
But what
Right.
areas are we going to be improving with this plan versus what we have now?
Well, I think I would just first blush give you a couple responses to that. One is that we're very interested in pursuing taking a population health approach. It's difficult to do that when we manage only part of the healthcare equation, and that's long-term care. Many of the folks that family care serves could be helped in stronger ways by being able to have all health care benefits put into the family care package, to be able to integrate all care, coordinate all care. We have an opportunity. That's for the health of the population that we serve. The other that I would mention is, and I've said this before various groups, it's not enough just to advocate quality of care. That's the most important, but it's not sufficient. The other piece that's important to advocate for is to make sure that what we do is sustainable, because we want our children's children to be able to have this same level of care in the future. And there are challenges to that. So we have to do two things. We have to be driven by quality, and quality and stewardship are not at polar opposites. In fact, quality drives cost containment, and that's our philosophy.
Okay, sorry to cut this off, but I think we just respect the time for the rest of the program for the day, and I'm sure some folks' stomachs are growling out there. So we're going to take a quick recess, but before we do, Ellen has a couple of announcements. So again, I want to thank you, sir, for coming, and all of you we'll see you all this afternoon. But Ellen?
Yes, I just want to let everybody know if they do have testimony in writing to please provide it to me. Someone did in the audience, so thank you for that. And then also for people on the phone, they're on a listen-only mode, but if they would like to ask a question, they can email me at ncdforums@gmail.com. That's the email that you've been communicating with, so please submit your questions that way, and we will try to get to them. One last note about lunch. It's on the second floor in the West Wing. We will meet promptly back at 1:30, so we don't have more time for lunch. Sorry. And please, if you're on the panel number 3, please gather a little bit before the 1:30 time. Thank you very much.